Specialized Rehabilitative Services. Appendix PP, Regulation Section 483.65, tags F825 through F826. Begin reading. Tag F825. Section 483.65, Specialized Rehabilitative Services. Section 483.6, 5A Provision of Services. If specialized rehabilitative services, such as but not limited to physical therapy, speech-language pathology, occupational therapy, respiratory therapy, and rehabilitative services for mental illness and intellectual disability or services of a lesser intensity as set forth at Section 483.120C are required in the residence comprehensive plan of care, the facility must. Section 483.65A1 provide the required services, or Section 483.65A2 in accordance with Section 483.70F obtain the required services from an outside resource that is a provider of specialized rehabilitative services and is not excluded from participating in any federal or state health care programs pursuant to Section 1128 and 1156 of the Act. Intent Section 483.65A12. The intent of this regulation is to ensure that every resident receives specialized rehabilitative services as determined by their comprehensive plan of care to assist them to attain, maintain, or restore their highest practicable level of physical, mental, functional, and psychosocial well-being. The intent is also to ensure that residents with a mental disorder (MD), intellectual disability (ID), or a related condition receive services as determined by their pre-admission screening and resident review PASAR. Guidance Section 483.65A12. Regulations governing PASAR are found at 42 CFR Section 483.100 to 138. For any questions or concerns regarding PASAR, do not cite here, but refer to Section 483.20E and K, F644, F645, and / or F646. Specialized rehabilitative services includes, but is not limited to physical therapy, speech-language pathology, occupational therapy, or respiratory therapy, and are provided or arranged for by the nursing home. They are specialized in that they are provided based on each resident's individual, assessed rehabilitative needs based on their comprehensive plan of care, and can only be performed by or under the supervision of qualified personnel. These services must be provided by the facility or an outside resource and delivered by qualified personnel as defined below in the guidance under tag F826 and who are acting within the state's scope of practice laws and regulations. The facility must provide or arrange for the provision of specialized rehabilitative services to all residents that require these services for the appropriate length of time as assessed in their comprehensive plan of care. These services are considered a facility service provided to all residents who need them based on their comprehensive plan of care and are included within the scope of facility services. Care provided by all facility staff must be coordinated and consistent with the specialized rehabilitative services provided by qualified personnel, which is defined under tag F826. Restorative services are not considered specialized rehabilitative service as referenced in Section O of the MDS/RAI Manual. Restorative services refers to nursing interventions that promote the resident's ability to adapt and adjust to living as independently and safely as possible. This concept actively focuses on achieving and maintaining optimal physical, mental, and psychosocial functioning, a resident may be started on a restorative nursing program when he or she is admitted to the facility with restorative needs, but is not a candidate for formalized rehabilitation therapy, or when restorative needs arise during the course of a longer-term stay, or in conjunction with formalized rehabilitation therapy. Generally, restorative nursing programs are initiated when a resident is discharged from formalized physical, occupational, or speech rehabilitation therapy. Probe Section 483.6, 5A12. Physical and occupational therapy. How did these services maintain, improve, or restore the individual's muscle strength, balance, range of motion, functional mobility, or prevent or slow decline or deterioration in the individual's muscle strength? How are these services maintaining, improving, or restoring the amount of activity the individual could do to maintain, improve, or restore their independence? Do these services assist an individual in minimizing pain to enhance function and independence? How are these services maintaining, increasing, or decreasing the amount of assistance needed by the individual to perform a task? How are these services maintaining, improving, or restoring gross and fine motor coordination, including sensory awareness, visual spatial awareness, and body integration? Do these services assist to maintain, improve, or restore memory, problem solving, attention span, and the ability to recognize safety hazards? Speech-language pathology. How are these services maintaining, improving, or restoring auditory comprehension, such as understanding common functional words, concepts of time and place, and conversation? How are these services maintaining, improving, or restoring the functional abilities of individuals with moderate to severe hearing loss? For example, is the individual instructed how to effectively and independently use environmental controls to compensate for hearing loss, such as eye contact, preferential seating, and use of the better ear or hearing aid? How are individuals who cannot speak or hear assessed for devices such as a communication board or an alternate means of communication? How are these services maintaining, improving, or restoring the functional abilities of individuals with swallowing disorders? For example, are muscle re-education, swallowing, positioning, or food consistency modification techniques being employed to restore, improve, or maintain safe swallowing function? How are these services maintaining, improving, or restoring the functional abilities of individuals with speech disorders? For example, are muscle re-education, positioning, breathing, or other techniques being employed to maintain, improve, or restore the individual's ability to communicate verbally? Respiratory therapy. How are residents assessed to determine which factor or factors may be involved in their underlying causes for ventilator dependence? How does the clinical team design and implement an individualized, comprehensive pulmonary rehabilitation program to include resident assessment, exercise training, education, and psychosocial support? Are qualified personnel caring for mechanically ventilated residents aware of risk factors for ventilator-associated pneumonia, VAP, e.g., nebulizer therapy, manual ventilation, and patient transport, and how do they practice prevention for these factors? How do facility staff implement practices to prevent VAP and other potential infections for residents on ventilator care? Refer to Section 483.80 Infection Control. What precautions do facility staff take to avoid accidental drainage of condensate into the resident's airway and to avoid contamination of caregivers during ventilator disconnection or during disposal of condensate? Refer to Section 483.80. Infection control. If the conditions that warranted placing the resident on the ventilator stabilize and begin to resolve, does the clinical team determine the patient's readiness for subsequent discontinuation of ventilator support and ultimately extubation? Is a gradual process implemented according to the physician's orders to wean the resident from the ventilator. How and to whom do facility staff report ventilator malfunction? Does the facility have a system in place to provide ventilator services for residents in the event of a malfunction of equipment? Does the facility have backup power to assure ventilators and other respiratory devices are operable in the event of a power failure? Refer to Section 483.90 Physical Environment Procedures, Section 483.6 5A12. For each of the services noted above, surveyors should determine through information obtained by observations, interviews, and record reviews that the facility not only delivered these services, but that the services and interventions, 1, were monitored for their effectiveness, and 2, assisted residents to attain or maintain their highest practicable level of physical, mental, functional, and psychosocial well-being, or to prevent or slow a decline. Condition. If the facility did not provide or obtain the required services, cite that here under tag F825. However, if the services provided were not appropriately assessed or delivered in accordance with a resident's plan of care, do not cite here but refer to the section below. Potential requirements for additional investigation. Potential tags for additional investigation, Section 483.6 5A12. For residents with MI or ID, their assessment and comprehensive plan of care must be coordinated with their PASAR. If this coordination is not done, or where it is clear that the resident needs a service according to their comprehensive plan of care and facility, staff failed to adequately assess the resident or has failed to care plan for the service, do not cite here but refer to Section 483.20 Resident Assessment and Section 483.21 Comprehensive Person-Centered Care Planning. Regulations governing PASAR are found at 42 CFR Section 483.100 to 138. For any questions or concerns regarding PASAR, do not cite here, but refer to Section 483.20E and K, F825, F825, and / or F826. If noncompliance with F825 has been identified, the surveyor may have identified concerns with related structure, process, and / or outcome requirements. If an additional concerns have been identified, the surveyor must investigate the identified concern. Do not cite any related or associated requirements before first conducting an investigation to determine compliance or non-compliance with the related or associated requirement. Other potential tags. Use of outside resources, Section 483.70F. Self-determination, Section 483.10. Quality of life, Section 483.24. Quality of care, Section 483.25. Resident rights, Section 483.10, for example, if there are concerns regarding charges to the resident for any of these services, refer to Section 483.10 F11. If an assistive device is needed for food and nutrition, refer to Section 483.60. Behavioral health services, Section 483.40. Infection control, Section 483.80. Physical environmental, Section 483.90. Key elements of noncompliance. To cite deficient practice at F825, The surveyor's investigation will generally show that the facility failed to do any one or more of the following: provide specialized rehabilitative services based on a resident's comprehensive plan of care, or obtain specialized rehabilitative services from an outside resource that is a provider of specialized rehabilitation services that is not excluded from participating in any federal or state health care programs pursuant to Section 1128 and 1156 of the Social Security Act. Tag F826. Section 483.6 5B Qualifications. Specialized rehabilitative services must be provided under the written order of a physician by qualified personnel. Definitions. Section 483.65b. Qualified personnel means a physical therapist, occupational therapist, respiratory therapist, speech-language pathologist, physician, nurse practitioner, clinical nurse, specialist, or physician's assistant, who is licensed or certified by the state to furnish therapy services. Qualified personnel may also include a physical therapist assistant, TA, or an occupational therapy assistant, OTA, when furnishing services under the supervision of a qualified therapist. Guidance Section 483.65b. The facility must employ either directly or contract with an outside resource the appropriate qualified personnel as defined above, and additional support staff to ensure the needs of the residents are met in accordance with their comprehensive plan of care. In addition to meeting the specific competency requirements as part of their license and certification requirements defined under state law or regulations, these personnel must have the training, competencies, and skill sets to care for residents as identified through resident assessments and described in the plan of care. Note: for residents receiving physical therapy PT, occupational therapy OT and / or speech-language pathology SLP services under the Medicare Part B benefit, an order is not required. An order from a physician may substitute for the required plan of care, although orders from therapists are not recognized. Although Section 483.30E3 allows a resident's attending physician to delegate the task of writing therapy orders to a qualified therapist, Medicare Part B does not currently recognize an order written by a therapist. Under current Part B requirements, when a therapy order is written by a qualified therapist, for that therapy to be covered and paid under the Part B benefit, a physician or recognized non-physician practitioner, including a nurse practitioner, clinical nurse specialist, or physician assistant, not a therapist, must sign and date the PT, OT, or SLP plan of care, which may be established by the therapist. In situations where there are differences between federal and state supervision requirements, the requirement with the greater level of supervision will apply. Only physical therapists may supervise physical therapy assistants, and only occupational therapists may supervise occupational therapy assistants. All speech-language pathology services must be provided by a licensed speech-language pathologist or by a physician, nurse practitioner, clinical nurse specialist, or physician's assistant who is licensed or certified by the state to furnish therapy services. Procedures Section 483.65b. During the record review, determine that these services are provided under the written order of a physician or therapist as delegated by the physician in accordance with Section 483.30E3 and provided by qualified personnel. If individuals providing specialized rehabilitative services, i.e., physical, occupational, speech, or respiratory therapy, are not qualified, cite here. If a problem in a resident's care or services is related to the qualifications, competencies, or training of personnel, i.e., facility staff, contractors, temporary staff, etc., also refer to nursing services not related to behavioral health care or dementia care, tag F725, or 726, Section 483.35a, c. Any staff caring for residents with dementia or a history of trauma and / or post traumatic stress disorder, tag F741, Section 483.40. Administration, tag F839, Section 483.70e. If there are any problems in quality of care related to restoring, maintaining, or improving a resident's functional abilities, determine if these problems are attributable in part to the qualifications, competencies, or training of specialized rehabilitative services staff. Also, refer to Section 483.25, Quality of Care, and Section 483.24, Quality of Life. Key elements of noncompliance. To cite deficient practice at F826, the surveyor's investigation will generally show that the facility failed to do any one or more of the following: obtain a written order from a physician or therapist as delegated by the physician, in accordance with Section 483.30e3, except as otherwise permitted with regard to residents receiving these services under the Medicare Part B benefit as explained above, or ensure that services were provided by qualified personnel. This concludes the reading of Appendix PP, Regulation Section 483.65, tags F825 through F826.